Okay, I guess we can start. It's 5 minutes past the hour now.
Yes, we can.
So good afternoon, everyone. My name is Olatunde Shode. So you don't need to adjust your set. It's not a little Sunday. But when your boss asks to stand in for him, you have to say yes. So I'm standing in for a little for this. I think a lot of us are familiar with this platform. The idea behind this platform is within the people, pediatrician practice within private practice space, to share ideas and to share knowledge. And today, I believe we have an interesting topic, which I believe is very valid and topical. And before I go on some few housekeeping stuff, we will require that please you mute your microphone during the call of presentation. And if you need to ask a question, you can put in chat box. And then at the end of the discussion, we'll probably have opportunity for you to ask questions at the end of this interaction. So I will now yield to our chairman, Dr. Femi Mugwale, to give the opening remarks, and then we'll be back to introduce our guest speaker. Thank you, sir.
Thank you, Tunde. I again welcome everyone to this meeting. Am I audible?
Loud and clear, sir.
Okay. Okay, so I thank Dr. Dushote for standing in for our anchor man, Dr. Elitu, who is unavoidably absent today. And like he said, this is a platform that was specifically created for pediatricians in private practice as a forum, as a milieu for sharing clinical experiences and scientific knowledge. And it's also open to pediatricians in public service or in private not-for-profit organizations who have an interest in private practice. And in that way, we have a PPP arrangement, which has proved to be very beneficial in the almost 1.5 years that it was started. Today we have a prominent member amongst us, Dr. Ngozi Onyia, who is going to make the presentation. Dr. Ngozi Onyia, you hear more about her. I like to describe her as a versatile pediatrician who, stepped out during the COVID pandemic to start treating adults with COVID-19. And so when, as a pediatrician, he has successfully treated adults with COVID-19, you can then imagine that pediatric patients with COVID-19 is so much easier for her. So we cannot have a better expert to do justice to this topic today than her. So I'll just stop at that and leave the rest to the moderator to say. So I welcome you all. I look forward to a very interesting session, and I thank you again for attending. Over to you, Dr. Odushote.
Thank you very much, sir, for the opening remarks. Well, it gives me a great pleasure to introduce my Egbon Ali. Our path crossed many years ago, and she took me under her wings as my big Egbon when I was doing my pediatric training. And I think the journey has continued since that time, although we have some few glitches. I'm sure she knows that we have those glitches, but thank God we are back together on a very good note. And I would say that there's no better person who's prepared among the pediatric group to talk about this topic, MIC in childhood. Like was alluded to by Dr. Movila about that. She's one of the people that actually took it upon herself to care for people with COVID-19. And the truth that if truth can be told, I'm sure she has a lot of expertise. She will say no, that she shouldn't hype her up. But so that there are very few doctors in Nigeria that had the kind of experience she had with COVID-19. And I'm one of the people that will going to continue to push her to write her journey, her story, even if it's a story in a book to read or a journal. I think more like journal and books to read, or we can learn lessons from my experience. So it gave me great pleasure to introduce my mom, my sister, Dr. Onyia, primarily a pediatrician, but also an entrepreneur in medical palace, and I'm also learning from Europe. So I yield to her to just go for it and share her thoughts. And I also want to thank the family of the patient who has been gracious to allow us to chat around their family. They are in the background. So I would just want to thank you for giving the opportunity for us to chat around your daughter. So Dr. Onyia, go for it. Thank you. You are muted, ma.
Yes, good afternoon. I was waiting for them to share my slide. And also to say my lovely patient, as nice looking as he is a boy. All right, so I'm talking about the multi-system inflammatory. No, I should start by saying good afternoon, everybody, and thank you for giving me the opportunity and the privilege of sharing about this case that I found very interesting. What is even more interesting was that having chosen this topic about 2 or 3 months ago, because it was, to me, a very interesting case. As I think just yesterday or 2 days ago, we discharged another child with a similar history. So clearly it's something that is here with us, something that we will need to always keep at the back of our minds. Every time there's a new wave of COVID, I'm sure we all know that COVID is here with us. It's not going anywhere. And therefore, every time there's a new wave, not tick, we should expect more and more cases of multi-system inflammatory syndrome in children, or MISC. A high index of suspicion is called for. So this is the outline I will follow in making my presentation. So in summary, I'm presenting the case of CA, a 5-year-old boy resident in the New England region of United States of America, who presented to a hospital in the US with a 2-day history of worsening fever, rashes, swollen gland, which was thought to be a parotid gland, could have been a submandibular gland. I must say that this child was in the US throughout this experience, and I was in Lagos throughout the experience. Okay, vomiting and diarrhea. He also had severe abdominal pain, I remember that. Retrospectively, history revealed that he had had a close contact with a COVID patient 5 weeks prior. He had had 2 COVID tests, which were negative after that contact, but the mother remembered that there was that contact about 5 weeks prior, and this is an important part of the history. He was initially being managed by his pediatrician in the US as a possible case of a parotitis, but eventually he was managed as a case of MISC using IV immunoglobulins and anti-inflammatory drugs. He made a very quick recovery. It was amazing how quickly he recovered after the administration of the IVIG at the correct dose. And generally, he's done well. Those of us who were on early saw him earlier. I'm seeing him for the first time myself, interestingly. But he still requires regular sessions for anxiety that was brought about by the severity of his illness. So he's quite an anxious child now. He's changed. He's not the same child he used to be emotionally. So, as we all know, COVID-19 was first discovered in December 2019. We all know that in the Wuhan region of China, etc., etc. It was the first global pandemic of such magnitude since the Spanish flu almost 100 years before. And it is rightfully considered a mild illness in children, very rightfully. Although I must also just point out now that because most adults have been vaccinated, and if most of the adults I will see have been vaccinated, and those who haven't been vaccinated have caught the infection once or twice, it has also become a milder illness in adults. And indeed, we are having more children presenting in hospital now with more severe illness than the adults. And although it is generally a mild illness in children, no different from the usual cough and colds, ARIs they have, occasionally it manifests with this potentially fatal illness. Early recognition, timely and appropriate intervention are required to reduce morbidity and mortality. I suspect that if a young man had the IVIG earlier, he wouldn't have stayed ill for as long as he did, and he wouldn't have, stayed ill for as long as he did, and become even as ill as he did today. So I'm also presenting this case as a background to highlight the fact that we have become a global world. There's benefit in physicians collaborating across facilities, across borders. You know, one of the good things that came out of the pandemic, COVID, is that now it's very comfortable to meet virtually. Very, very comfortable. So all these meetings we're having, like if we had to all drive to Luther, to ML or somewhere to meet, fewer people will be attending these meetings. But I know some of our mates, some of our colleagues are attending from the north, from the east, from all over Nigeria. So just as we can do across Nigeria, we can also do across the world. During the pandemic, I did consult quite a bit with physicians in the US, infectious disease specialists in the US, mostly because they had relatives who were on admission in a center. So they will call to ask me how their relatives were doing, but then I will also ask them questions, and together iron sharpened iron, and I think we all learn from each other. So the pandemic, in my opinion, at least this illness, COVID itself, has reduced the world to ground zero. So nobody knew anything about COVID before 2019. We all were learning on the go. And so it doesn't really matter where you are in the world. What really matters is how much experience you've had with COVID, how much knowledge you've acquired because you are interested. And because of our involvement that Tunde alluded to earlier in the management of COVID, we are almost like local COVID experts across board in the hospital, everybody, even our medical officers who were involved with us. Because, like I said, we were learning on the go, So this new one has come up, that new one has come up. We tried, we observed, and so on. And much as I really appreciate research, and I realize the importance of research, the honest truth is that I think the biggest public health intervention of all times was actually discovered by a local GP that worked in a farm who noticed that milkmaids who caught cowpox didn't get smallpox. Well, the local GP, he wasn't some big high-tech scientist in a big center. So we had, like, again, one of the benefits of technology, we started a WhatsApp chat group on the 3rd of May 2020, and the WhatsApp chat group is still ongoing. It's called Ikeja Payment, and I think Tunde is on that group. Okay. And we learned so much by the things we saw during the pandemic. Next slide. So the case I'm presenting a 5-year-old Caucasian boy who lived in the United States of America. He complained of fever, lethargy, and feeling he had water in his right ear on Friday, August 5th. So he went to bed early. He woke up the following morning feeling better, and that's so typical of COVID. It's so typical of COVID, feeling better. He still had a temperature, but he felt better. And his pulse rate then ranged from 100 to 110. He was still tired, but eating actively. So I'm just writing his mother's notes as she sent them to me. Playing with his brother. His fever continued through the day, and his breathing started sounding congested at night. So a running nose, very typical of COVID as well. And of risk. The fever was higher the following day, and getting as high as 39 degrees centigrade. And his right parotid gland was swollen slightly. It could also have been a top of the blood gland. Though tired, he was still playing and eating, and his doctor prescribed oral antibiotics, so I suspect they were taking him to see a doctor, and eardrops. His temperature spiked higher overnight to 39.4, and his pulse rate went up to 120 to 30 beats per minute. And whilst we do know that a fever will cause tachycardia, but one of the organs most vulnerable to the COVID-19 virus is the heart. And tachycardia is often, please can you go back? It's often please go back. It's often a feature of COVID in adults and children. His breathing became shallow and slow, and then a bruising on the left ankle shoulder. Please go to the next slide, thank you. He woke up the following day, which was Monday, the 8th of August, with a temperature of 40. The lethargy was worse, the gland was now red and more swollen, so his parents took him to the ER, concerned that it was an adverse drug reaction to the antibiotic. Also, he had some mottling of his face. I'll show you pictures later. The ER doctor was concerned about the enlarged gland and asked for a CT scan. and started him on intravenous antibiotics, I think ceftriaxone and clindamycin. And then he gave 1 dose of steroid, which was probably the best thing he did. But he gave 1 dose of steroid. He took blood samples for investigations, and then the bruising on the left ankle worsened, and now a bruise of the right ankle. Prior to this, he had been a very healthy child with no history, no previous history of hospitalization. And on June 19, this is just going back, he and his brother had a fever and vomit. He vomited 5 times that day and 2 times the next day. They both tested negative to COVID after that. And with the benefit of hindsight, because when I got involved, I asked his mom, I sent his mom actually some information on MISC, patient information on MISC, and she read it and called me immediately and said, yes, he did have a contact with close contact with patient with COVID, but he had 2 COVID tests after that and tested negative both times post the exposure. This is so typical of MISC. So there's the history of a contact 2 to 6 weeks, but average of 4 weeks before the patients come down with this multi-system inflammation. So I got involved in this care when his mother's friend, whose children I look after in Lagos, asked me if I would mind giving a second opinion to her friend. I actually thought the friend she was talking about was a local friend. So it was quite surprising when I realized I was talking to a friend when I saw the phone number, okay? As soon as I saw the results, so the friend who had called me sent me some results. And as soon as I saw those results, I said, this is MISC. It was too obvious to me. And then she sent also the picture of the blotching of the skin. And I sent the mother the literature, and then she called me and said to me that there was a definite exposure 4 to 5 weeks prior. So I had very little doubt that. I asked her to discuss with the managing pediatricians, and as we can expect, there was a bit of resistance. Most of us mind very much when other doctors appear to be interfering with what we are doing. But I think more and more we should, in the interest of our patients and in the interest of gaining knowledge, maybe broaden our minds so that we can listen to other people and maybe they just might have the secret to what you're saying. So so they were worried that it was, the pediatricians were worried that it was becoming an abscess. So despite the heavy antibiotics, it was on ceftriaxone, clindamycin. So they did a soft tissue scan, and that showed that there was no abscess. Actually, I spoke to them, I think, before that soft tissue scan, but they were still convinced it was a soft tissue. It was an abscess. When we look at the lab results, it was obvious to me that this was not a bacterial infection and that the antibiotics were really not very important. His fever was unremitting. He became dehydrated and was no longer able to eat. He became now lethargic and became a very sick child. Actually. In fact, at this point, his mother and I were now praying for him. It was that illness. It now had become a prayer point. And in the end, which changed the slide, sorry, a bit of, He also developed severe abdominal pain, diarrhea, vomiting, and all that. Then also he now developed inflammation of the scrotum. That seems to be, I don't want to call it, but it seems to happen very often with children who have MISC. So MISC is a rare condition, but the few children I have seen with MISC also now have either an inflammation around the scrotum, which could be an otitis. Like I said, I didn't examine it, I can't tell, but the mom was concerned about that. And then the blotching spread all over the body to the face. It became hypotensive at the point, and its inflammatory markers were rising off the charts. Okay, so they finally agreed to do a COVID antibody test. It was positive, and then they started him off on IVIG, and they stopped all the antibiotics. By the next day, like magic, all the shock that he was going into reversed, his blood pressure normalized, he became much more healthy. His fever stopped, was discharged the following day, which was on a Sunday, and followed up by a cardiologist because it was important to ensure that he didn't develop a vasculitis down the line or any such thing. Okay, and I said, I'm still in contact with the mom and she was this call. So these are the investigations that I have. I brought out what I thought was relevant. Please go to the next slide. I have lots of results, but just for us to see the progression of the inflammatory marker, CRP. So on the 8th, it was 152. It went down to 99 because he was giving me steroid. But then it went back up to 198, 228, and then when they started the IVIG, it started going down. The D-dimer was elevated, but started going down also after the IVIG. Okay, this next slide. His hemoglobin, he became a bit anemic, which is not unusual. The child I had on admission that had just been discharged also became significantly anemic to the point where we offered him transfusion. I think his own hemoglobin went as low as 8 something. Then look at the total white cell count. Was 7.2, 6.8, 9.4, 10.1. It was always normal. Okay. But his neutrophils were also always normal. So 5.6, 5.6, 7.5. It was only on the 12th it became 8.2, which was 0.2 above the normal total granulocyte count. But very quickly after the IVIG went down to 2.9 and 2.63 as absolute numbers. The lymphocyte count, again, very important. Look at how low it was on the 10th. It was 0.77, below 1. So a lymphocyte count of less than 1, an absolute lymphocyte count. So a lymphopenia is often suggestive of COVID. I know malaria also gives us a relative lymphopenia, but COVID, so classical, it's almost impossible to see classical COVID without a relative lymphopenia. So if Tunde remembers, he will often see comment like, this full blood count looks very COVID-y, to the point where during the period of the pandemic and even up to now, we often will go ahead and manage as COVID, even when the PCR is negative. And I'll tell you the reason why. The PCR, there are many reasons for false PCRs, many reasons. The most important one, in my opinion, is sample collection, poor sample collection. So it's a very irritating process. Most patients will push back as they're trying to put the swab down the nostrils. And therefore, most samples are actually collected just from the nostrils rather than from the nasopharynx. And therefore, of course, we will often get false negative results. But when we see the picture of normal to low total white cell count, and then very significant lymphopenia, and of course, a relative neutrophilia. So in reality, it's not a neutrophilia. And I think that's one point I will highlight at the end. It is not a neutrophilia. It is just relative because of the lymphopenia. So it is really a lymphopenia, not a neutrophilia. Okay. And then the platelets are normal. That's a good way to distinguish between malaria and COVID, because sometimes they have very similar full blood count pictures, except that malaria will often be associated with thrombocytopenia. Okay, next slide. Next slide. No, please go back. You've jumped a couple of slides. Okay. So the back, please. So the chemistry, there are lots more investigations, but the ones I think of significance. Very often the liver is involved. Luckily, his own liver was not involved. So his liver transaminases stayed normal. But for example, the child I just discharged now had elevated transaminases, AST, ALT. His glucose was considered high, but in my opinion, his glucose was normal. But going by their own reference ranges, it was flagged as high. But in my opinion, it was normal. A common feature of COVID is hyponatremia. He did have hyponatremia. the very common feature. So the common features of COVID are elevated transaminases and a hyponatremia. If, unfortunately, the kidneys are involved, there's also often high creatinine levels. Luckily, his creatinine levels stayed normal. So one of the questions, please, next slide. So other investigations that were done, cultures for staph and strep were both negative. The COVID antibody was positive. And I think let me just say some things now rather than following the pattern before I forget the things I need to highlight. One of the questions that the mom asked me, which I'm sure the pediatrician asked, was multi-system, which systems? So for him, clearly, his skin. So it's one more than two systems are involved. So his skin was involved. Clearly, his heart was involved. He had tachycardia. Then his blood, because he had the typical lymphopenia. Oh, of course, I forgot to mention in his own case, he also was now getting involvement, probably of his genitourinary tracts. Okay. And then something else that's important to mention here for those of us who practice in Nigeria. So we don't do this very interesting nucleocapsid antibody serum. What we just do are those rapid test strips. And the truth is, once a patient has had COVID once, you will never have IgM again. So it's very unusual to see anybody with a positive IgM now, even when they have COVID, because once IgM is for the first exposure usually, and then subsequent exposure will give IgG. So yes, it was easier when at the beginning of the pandemic, when with an IgM, you will know that there was a recent COVID exposure. Now, even when there's a recent COVID exposure, what you will have will be a positive IgG, not an IgM. So I think we'll still go by the guidelines, positive antibody COVID. His ECG, his echo that was done initially showed a trace of mitral and aortic incompetence. Insufficiency was the word used, not, please go back. Please go back. Insufficiency is the word that was used, but he followed up on the, like a month later, and ECG normal, echo normal, no vasculitis, nothing. Please, next slide. Next slide, please. So what are the differential diagnoses? Initially, otitis media and the parotitis. And then they talked about a parotid abscess. And then finally, MISC was considered. So the classic history of the close contacts 5 weeks prior and positive antibody test, I think also finally convinced the pediatricians in the US. And the prompt response to the IVIG showed that clearly it was an inflammatory condition we're dealing with. Next slide, please. So what treatment was given? The standard treatment should be IVIG, steroids, and other inflammatory drugs. Those are the recommended treatment. For him, it was IVIG and probably other inflammatory drugs. He was probably on an NSAID for his fever. The steroid, 1 dose was given initially, but the pediatricians were very reluctant to give subsequently, and he did very well with the IVIG alone. But just to mention that the guidelines, treatment guidelines, discourages the IVIG monotherapy. And I must confess that I know that, but because I was away, I just got in last night. So the other child who we managed with suspected MISC was managed in my absence, and I wasn't present to see the child. So when we eventually gave IVIG, first and foremost, we did the wrong thing, I must confess. We gave a suboptimal dose because you see, I wasn't 100% sure, I wasn't clear about what information I was getting. I wasn't talking to the mom this time, I was talking to medical officers. And so we gave 1 milligram per kg. We should have given 2 milligram per kg, that's the recommended dose. And then we also gave a low dose of the steroid. The recommended dose of the steroid is 2 milligrams per kg, or 1 to 2 milligrams per kg should be given of methylprednisolone. We didn't do that. And that child also didn't recover as quickly as he might have if we had given the 2 milligrams per kg of the IVIG. Also, of course, in that case, not only was I not there, because I was not there, the parents gave the other doctors a hard time. Okay. Next, okay. So he made a full recovery. And as we saw, the inflammatory markers almost became half after one dose of the IVIG. And the lymphocyte count normalized from 0.77 to 1.something. He was discharged home on the 14th, after about 48 hours fever-free. And by the 15th, I received this message from his mom. Good afternoon, your little patient is on his way to healing. He's home resting and he has had 6 pancakes. Wow, wow, 6 pancakes for breakfast with a spinach smoothie. He went back to school on the 31st. But I got further feedback from the mother. He had become a more anxious child. He's emotionally not the same child he was. He was a happy-go-lucky, playful child before. Now he tends to be a bit more irritable and gets angry. And then he's also a bit fearful because I think he realized that he was very ill. And he saw his mom's anxiety during that period. His follow-up with the cardiologist showed a normal ECG and echo. Next slide, please. So it mostly affects school-age children, 8 to 9 years. But as we can see, a young man is 5, and the child I managed recently is 7 as well. It can also be seen in infants and young children. It is an inflammatory reaction in the body triggered by the COVID infection, pure and simple. It's just a cytokine storm, just the same as we have in adults. It's just an inflammatory reaction triggered by the virus. It occurs usually on the average 4 weeks after the infection. And most children will still have antibodies to the virus in their system. The initial symptoms, so here was the classic case: fever, rashes, diarrhea, vomiting, red eye, here abdominal pain, and then involvement of the cardiovascular system, liver, kidney, can lead to very serious disease. It has many features in common with toxic shock syndrome and Kawasaki disease, which of course was why it was noticed the first time that children who have, that there was a clustering of Kawasaki-like disease during the pandemic. That's how the disease was discovered, the clustering of Kawasaki-like disease during the pandemic. So just to say that there are myriad ways, not waves, sorry, of manifestation. So COVID can manifest like anything. I remember as a medical student being told by, I don't remember which of our internal medicine professors, that malaria is a masquerade. I think if malaria is a masquerade, it's a small masquerade. So for those, the Igbo-speaking people, while malaria might be ulaga, COVID is the big masquerade, you know, it can present as anything. There's no typical symptom of COVID. And so we just require always a high index of suspicion. I think we should recognize that COVID is going to be with us for a long time, maybe forever. I think forever. I think it's just normalized. It was very nice to travel again with no mask. I didn't wear a mask at all. I was in a training for 5 days in a closed group. People were coughing like crazy. Nobody wore a mask. Yeah, so that's COVID for you. And I'm sure some of the people coughing had COVID. So, but when there is a wave of COVID, we should realize that we will have more and more mistakes. So when we see children with those symptoms, including swollen glands, blotching of the skin, of course it won't come out as nice as it came out in my patients because our own children are mostly dark-skinned children. But even the child who we just discharged from the hospital also had rashes. It was one of the things the mom complained about. And in his own case, in fact, it affected his palms. Okay, and soles. So I already talked about the lymphopenia, which misleads us into thinking it's neutropenia. And in my opinion, particularly for us in our own location, the most reliable inflammatory marker that I use is CRP. You can always monitor with CRP. If you must do 2 investigations, then I guess you shouldn't do only 2 investigations. But if you must, CRP and a full blood count, very important. Then of course, we need to monitor the liver and the kidneys because they can be involved. Let us also remember the heart can also be involved. Sometimes there's a terrible vasculitis that actually can be fatal. And then also to say that it was nice to be able to collaborate with my colleagues in another country, virtually, and together we came to a conclusion that helped our patient get better. Next slide. So just some pictures, I think. So those are the blotches, we can see them, the leg. The swelling around the submandibular region that made them think he had a parotid abscess. Next slide. That was him really very ill. The picture to the left, that's when we were really, really worried about him. He was really ill at that point. And then that was the picture the mom sent to me in September. He had gone back to school, and so this was on the 31st of August, I think. He had gone back to school and he was quite well. So he's the smaller of the two children, and that's his big brother. Thank you. I think that's probably my last slide. Next. Oh, okay, so the patient perspective from the mom. So it's nice to hear what some of the mom's comments. She said, I remember holding him every night to feel his body temperature, praying he wouldn't spike a fever. Every night between 2:30 and 4 a.m., he would, and I could feel it against my body. I'd kneel beside his bed and pray and cry, walk the room, covering him in the blood of Jesus. Both of us are still shocked that what was a minor initial diagnosis morphed into a life-threatening illness. It exposed the consultant's assumptions as being rooted in the probability of a minor infection rather than using the evidence to ascertain the possibility of risk of Kawasaki disease, even when the lab work was clearly indicating the required path of treatment path. Next slide, please. Our son now requires regular counseling sessions to address the harrowing experience he underwent as the doctors treated him incorrectly. He could see fear on our faces as we watched him deteriorate. He's become short-tempered. He exhibits fear when his friends come down with an illness, however minor, as he frets that his peers will undergo a similar experience. He won't go into rooms by himself or upstairs alone like when he did before being in the hospital. My son said he remembers mommy sleeping in his bed every night in the hospital and never leaving. He remembers getting really cool Lego, and when they took the blood, it was the worst. And that's something nice. Thank you very much.
A wonderful and lively presentation that you made what was difficult look so simple. So it's now time to ask questions. If you want to type in chat box or want to just raise up your hand and can ask to unmute and ask question or comments. Thank you. So it's time to ask questions, comments. Or if you want any area of clarification, something, okay, I can see a hand up. You can please unmute and just ask a question. Dr. Ifadi, please go ahead, ma'am.
Thank you very much. Ngozi, thank you very much. Thank you for this lovely presentation. Every time I put down a question I wanted to ask you, you talked about the thing I wanted to ask about. I wanted to ask you about the heart, you mentioned it. I wanted to ask you about Kawasaki, you mentioned it. I do have a question about the bruising, and I was happy that at the end you said it may not be clearly visible in our skins, but will be quite visible in the white skin. One thing I missed the D-dimer when you put it up. So I don't know what the number, I can't remember what the number is. But I noticed that the platelets were beautiful all through, except at a point when it was like 140. I also noticed that it seemed as if I missed the clotting as well. So I couldn't really put together what the bruising was due to. Maybe it's a rash, but I couldn't, in my head, I was trying to figure out what had caused the bruising. Is it the virus itself doing its own thing? Or was any of the investigations, did they come up as being abnormal? It's also quite interesting that you have pointed out to us that the disease the illness seems to come up weeks after the previous contact. So many times, even in this regions where the parents are so focused on what's happening, they forget, and you may never get that history that there was a contact with COVID. And I've seen a few cases where we had to come to the conclusion that perhaps they never come out in contact with COVID in the previously, but they tend to forget that they have that contact with COVID. I also want to ask if now, you know how they describe Kawasaki, that you have to have a fever that has been going on for so long and 4 or 5 other features. Have they given a description for MISC like that? I think for me, and you said it, a Valina group, I think they had quite a few patients, and they were the one who said it was a Kawasaki kind of illness, when it first came up. The final thing I want to say is that more recently, COVID is going nowhere. COVID is with us. More recently, we're seeing newborns and babies under 3 months presenting with features that look like severe sepsis. At the end of the day, all their cultures come back negative. And these babies, unfortunately, have to have lumbar punctures and examine the CSF. The only thing we find that is positive is COVID. We still don't have the courage to give them antibiotics. We still give them antibiotics. We treat them for at least 5 to 7 days with intravenous antibiotics. But it's just for us to remember that COVID is very much with us. It's not going anywhere. It's evolving, showing its face like a masquerade, like you described it. And truly, because the adults are not immunized, the children are the ones presenting with COVID. Thank you very much. Thank you for your beautiful presentation.
Thank you, Dr. Olifade, and I'm glad you have seen the patients as well. So maybe you'll make the next presentation on COVID in children, because I don't think we're talking enough about it, because we're all under the illusion that it was a very mild illness in children. I think the rashes, the blotching on the skin, probably a vasculitis, a microvasculitis is probably the major reason. The platelets stay normal in COVID, and indeed is a way of differentiating for us between COVID and malaria, normal platelets. And I think I'll try to look for the WHO guidelines, which I should have looked for before now, but if anybody sees before me, in the definition of the MISC, it says 2 or more systems. Involvement of 2 or more systems makes it the multi-system inflammatory condition, multi-system inflammatory syndrome in children. And there's also a history of a recent contact with COVID and a positive antibody test. So those are the criteria, 2 or more, yeah, 2. And it's a Kawasaki-like illness. Okay.
Thank you very much, Ma, for your response. I just want to ask Dr. Fadi this. The culture that was done for the kids, did you do bacterial genomics to see whether there's something that was missing for the neonates? Just a curious question I just want to ask.
So, no, is the simple answer. But basically, I know you would ask that question because in our environment, we don't even do cultures. But here, before any child who comes in with sepsis, baby or older child, within 30 minutes to 1 hour, must have antibiotics put in. And once you put a needle in the child, you must do a blood culture. So our blood cultures relatively are pretty reliable. You know, if a child has an organism, it is picked up in the blood culture. There is no other way to describe what happens. If it's not picked in the blood culture, it's picked up in the urine, it's picked up in the CSF, it's picked up in any body fluid that is cultured. So if a child has sepsis, bacterial sepsis, there's no doubt that you will pick it up.
So I think we are losing you there, ma'am.
Oh, I said the simple answer is no.
Okay, well,
we heard her very well. So the problem with you today, because we heard her very well.
Okay.
Sorry, I have the list here. So it says the criteria, it says an individual aged less than 21 years presenting with fever, laboratory evidence of inflammation, and evidence of clinically severe illness requiring hospitalization with multi-system organ involvement, so greater than 2. So it's cardiac, renal, respiratory, hematologic, gastrointestinal, dermatologic, or neurologic. For him, he had hematologic, he had dermatologic, he had gastrointestinal, and in my opinion, I think he had cardiac because of the tachycardia, which also showed as mitral and aortic insufficiency initially, but reversed. And then there's no alternative plausible diagnosis and positive for current or recent SARS-CoV infection. That's the problem, that's recent SARS-CoV infection. This definition was in 2020. In 2022, when most people are being reinfected, I wonder how seriously we can take that. Or antigen test or exposure to a suspected or confirmed COVID case within 4 weeks. So the fever will be greater than 38 degrees for greater than 24 hours.
Because is that a Royal College or WHO?
CDC.
CDC. Okay. The Royal College website has a big...
I will forward you to the link, to the pediatric link. Okay. Okay, I've just sent it to the group.
Thank you very much, ma'am. I think my own network is acting up. I can see the mother of the kids that wants to just make comments. Can you please unmute and just go ahead, ma'am?
So first, I would like to say thank you so much to Dr. Ngozi. I will try not to get emotional, but it's very difficult. We truly believe that Dr. Ngozi saved our son's life, and we are so grateful for her. The doctors here in the US would not consider her diagnosis because it was so early. So I find that she's also being very humble. They were refusing to do the antigen test because by their standards, he had to have 2 or more organs in failure. And he would have had to have the fever for at least 2 weeks. And because she diagnosed this so quickly, within 3 days of him having a fever and getting ill, they were not willing to follow that diagnosis. And Dr. Ngozi stayed with me every day in contact, multiple times, day and night, responding to text messages, and really just kept us fighting for him and fighting to get them to listen to us and to consider her diagnosis. And she took her time to call the doctor, our pediatrician that was working with us in the US, and to advocate for him and for them to listen to what we were saying about the test that we wanted run. And she saved his life. We thank her so much. We're so grateful for her. Sorry. But she is also being very humble because in the US, they said that they had never seen at least the doctors that we were dealing with had never seen a diagnosis that quickly on Miss C. And that's why they were struggling to follow her recommendations. So thank you. I'm done now.
Thank you, Shannon.
Thank you very much for just sharing your thoughts with us. And that was very huge and very kind of you, ma'am. So if there are any questions or comments, I'm trying to be the Jebu man in me because I think my network's acting up. That's why I'm not showing my video. So if you have any question or comments, please, you are welcome to do so. You can just put up your hands and then we'll recognize you and you can now unmute. I guess my Igbo has done a very good job. So we are waiting for the articles, the journals, the write-ups to come. No, you won't say no to me. I know I have your PIN number. I know I have your PIN number. You are muted, Egmont. I know you are still muted.
I think you can write them up for me if you like. NIMA is still publishing our data. I don't have a head for writing things.
Okay,
now.
No problem. Okay. So any question or comments, please, will be welcome. I think we've had a wonderful session. I can't see any hand now. Well, if there are no questions or comments, I can just say thank you to my dear Egmont for a wonderful job you've done. And I'll yield back to Dr. Ngozi for closing remarks. Thank you, sir.
Well, thank you very much, moderator, for asking me to say a couple of things again. I particularly thank Dr. Onyia for coming up to give this case report and highlighting the importance of being able to meet virtually. This organization was born in the midst of COVID-19, and we started these virtual meetings then, and it has stuck. It has become a way of life for us, even when physical gatherings are allowed. Of course, the reaction of the mother of the patient is very important lesson for all of us. And I don't know whether Dr. Onyia will recollect at the very beginning of the pandemic, when I spoke with her, I advised very strongly that she should document and attempt to write up her experiences. I think Dr. Dushote had mentioned this, because this is a strange illness, and everybody all over the world, can you hear me?
Now we can hear, yes.
Yes,
am I audible?
Yes, sir, you are loud and clear, sir.
Okay, so I was saying that earlier in the pandemic, I had discussed with Dr. Onyia the importance of documenting every single thing that she's doing there, because I could see that all over the world, everyone was struggling with this new disease. And so, like she rightly pointed out in her presentation, it was ground zero for everybody. So everybody's experience really matters. And the fact that, you are acquiring your experience locally here, even in resource constraints, does not, necessarily minimize that experience. And I'm happy that she's beginning to, come out and put them out and everything. And this case presented today is one of the success stories, how her local experience has really helped to save somebody across the world. So, I really feel touched by the whole presentation, and I'm happy that we as pediatricians have learned one or two things about collaboration. We have emphasized it before, collaboration amongst ourselves. We have seen how it worked internationally, how much more locally, where we have easier access to each other, is very important. And I think this platform has provided a forum for that. We have seen people come up with difficult cases for discussions and so on. And I want to really encourage this. So I thank the presenters, I thank the parents of the child for being gracious enough to allow this presentation to take place. Thank you very, very much. We are grateful to you. And I thank Dr. Onyia for an excellent presentation. And Dr. Dushote, we have found an assistant for Dr. Iletu now. So you have been co-opted. Thank you very much indeed. Over to you again, Dr. Dushote.
You're welcome, sir. I'm a loyal boy. I'm your boy anytime, sir. Well, just thank everyone for being part of today's meeting. The next meeting will be announced, will be advertised. and I believe it will promise to be another exciting meeting for all of us. Shortly after now, the link of this or the recording of this telecast or Zoom meeting will be available on our YouTube channel. So we can go back and watch again and again. So on behalf of everyone and my big boss, Sendrele, who co-opted me last minute, say thank you for joining on this platform. Thank you, my big Egbon, for doing a very wonderful job. And Dr. Morella, thank you for the privilege to be part of this and for your leadership. So till next time, God bless. Thank you.
Thanks so much. Thank you for all of your help.
Thank you. Bye-bye.